is pretty much emergency medicine. I still also work on the streets in a flag car in the city of Torrington. So I do respond to a lot of these overdoses throughout the years.
Next person on the list, Ralph Baker, would you like to introduce yourself, please?
Good evening, everybody. My name is Ralph Baker, and I work at Charlotte Hungerford Hospital. I'm a community case manager. I'm a certified addictions counselor and a case manager through the hospital. As I said, I'm about to complete my bachelor's degree in psychology at Post University, and I do outreach work in the community and as patients come through the hospital. I'm currently working with Sergeant Kelly, who you'll meet later, in the Torrington Police Department, where I'm responding to overdoses as they occur, offering services and trying to help the families of the people that overdose as it occurs.
And I'm going to ask Sergeant Kelly to introduce himself, please. Maybe he had an IT problem. He disappeared. He was on the call. When he joins back in, I'll circle back to him. Next person on the list is Sarah. Would you mind introducing yourself, please?
Sure. My name is Sarah Toomey. I'm a community outreach and recovery navigator at Greenwood's Counseling and Referrals in Litchfield. I cover all of Litchfield County, mostly the more rural communities. And I do a lot of overdose follow-ups, data tracking for overdoses, harm reduction rovers, and very involved with the Litchfield County Opiate Task Force. Thank you.
Thank you. I see that Brandon just logged back on. Brandon, do you want to introduce yourself, please?
Yeah, sorry about that. I just lost connection. Brandon Kelly. I'm a sergeant at the Torrington Police Department. I've been on the job for just over 11 years. I'm currently in charge of day shift patrol, normal patrol, but I'm also involved with the opioid outreach, which we'll go over in a little bit later. I'm also certified in CEIT, which is crisis intervention, team training, and mental health first aid. So I'm one of the instructors in the area and in charge of teaching a majority of guys about mental health and substance abuse, addiction issues and disorders. And I coordinate a lot of the services and programs.
And Lauren, will you introduce yourself, please, and kind of tell everyone your role in this work, please?
So
it looks like Brandon's.
Yeah, there you go. No, you're good. There you go.
He's back. Okay. Hi, I'm Lauren Pristo. I'm the network coordinator for the Litchfield County Opiate Task Force. So I oversee many of our different programs and a lot of the different tasks associated with the task force.
You'll notice that in the bottom right-hand corner, I put the name of the person who's going to talk to that slide. So just for the speakers, just keep your eyes open for that bottom. If there's no name at the bottom of the slide, then that slide is assigned to myself. When you're done with the slide, you could just give me a thumbs up, and then I'll move the slide forward. So, Brandon, all right, Sergeant Kelly, this is your slide.
All right. Sorry, my phone's definitely not behaving itself.
I don't see the slide.
Oh, let me make sure I'm sharing them. Can you see the slides, Ralph? Okay. Brandon's connection is weak, and we can't hear you, Brandon. We have a little IT issue, so I'll just jump in. Or Sarah, do you mind jumping in and talking, talking to this slide? Or Brandon, are you getting a better connection?
No, he's out.
Okay. Sarah, do you mind talking and kind of talking about some of the objectives,
Can you
please?
hear me now?
I can hear you, Brandon.
I just want to make sure that, all right.
So some of our objectives for today's presentation, we're going to talk about the current opioid crisis as it impacts Litchfield County, as it impacts all the work that we do as the opioid task force. Throughout this presentation, you're going to hear references to the Litchfield County Task Force, the work that we do as a task force for the community. We'll also give you information to how to get help, not just for an acute overdose, but help for rehabilitation. We're talking about basic strategies as well for harm reduction. And so we know that people may use if they're addicted. So we'll talk about some safety steps that they can take when using. And I don't look at that as encouraging people to do bad things, but it's the reality, it's the addiction. So we want people to be safe. We'll also talk about how to respond to an acute overdose throughout this presentation. Some of the information will be repetitive, so we planned on repeating important information. There is a video that was developed by the manufacturer of Narcan. So I'm going to play that 7-minute video because it really does a nice job of capturing everything. And that will allow us to concentrate on what we're doing as the Litchfield County Task Force and how we can provide help for the community.
We can't see the slides again. There we go, perfect. So as I mentioned earlier, I do a lot of overdose tracking and tracking of different information that comes across from a couple different systems. We get information into Overdose Map. We get information from the Office of Medical Examiners, and it comes from a lot of different places. So I put together some information on Connecticut accidental overdose deaths, and there's some trends that we have seen over the years. So in 2015, there were 723 deaths, and each year since then, it has gone up. In 2020, Litchfield County was the only county in the state of Connecticut that actually didn't have an increase in overdose deaths. So we were slightly under what we had last year. So this is data that is across Connecticut. In 2020, there were 1,375 deaths. In Litchfield County, there were 69 overdose deaths. But some interesting information that we've seen is the changes in what we're seeing in these deaths. The substances that people are overdosing on has changed significantly. So in 2016, 55% of the overdose deaths included heroin. And in 2020, 19% included heroin. Fentanyl started to increase in 2016, and throughout the years has gone up. And so now in 2020, 85% of all overdose deaths included fentanyl. And I think that number is going to be even larger this year. Cocaine has been significantly increasing in overdose deaths because it's being laced with fentanyl. And something that might be new is something called xylazine, which is a horse tranquilizer that comes from Puerto Rico. And so that came about in 2019. There was 6%, and now in 2020, 10% of the overdose deaths in Connecticut had xylazine. And again, we're going to see that increase over this year. So the substances are changing. We're seeing a lot of different things being laced with fentanyl, pressed pills and other things we'll talk about in a little while. But it's definitely changing, and it changes year to year.
Thanks.
So what are opioids? We talk about opioids being prescription painkillers or street drugs. At some point in everybody's life, or you or a family member has probably been prescribed some sort of opioid. They activate the pleasure part of the brain and relieve the intensity of pain, So we're not necessarily talking about always physical pain, but it could be emotional pain, trauma, depression, anxiety, other things that people are feeling. And so when somebody's getting addicted to a drug, it could be, I took this Percocet and I've been waiting for this feeling my whole entire life. They are synthetically or chemically made. It includes heroin, fentanyl, and carfentanil. And they're prescription pain relievers like oxycodone, Percocet, hydrocodone, Vicodin, and many, many more.
The complications of opioids. Opioids basically, when taking in an overdose, cause respiratory depression or possibly even respiratory arrest. Also can cause a patient to go into cardiac arrest and ultimately die of that overdose.
So when an overdose occurs, it's because a toxic amount of drugs or combination of drugs or medication has been consumed. They are overdoses from stimulants. They have different symptoms and require a different response. So if somebody's overdosing from a stimulant, naloxone or Narcan may not work unless there is fentanyl present. So naloxone or Narcan only works on an opioid overdose. It's not going to work on straight cocaine, alcohol, Xanax, unless it's being laced with fentanyl. In that case, then naloxone will work. And so it's better safe than sorry to administer the Narcan if you're not sure what the person has ingested.
And, you know, we think of who's at risk for an overdose, you know, and when Jeff and I were first talking in the beginning of the presentation before it started, we talked about, we were sharing stories with Ralph, and we got into EMS in the early to mid 80s, and you didn't see a lot of overdoses. You didn't see a lot of the heroin, should I say. What now I was telling Ralph that we would see a lot of people using speedballs. So it's the mixture of cocaine and heroin. And you always kind of put people in a category that you encountered. And as you get older and more mature, and you realize that we could be affected and impacted, our families could be impacted. In fact, a lot of us have our family that's impacted. So when you think about who's at risk, we're all at risk. I've had multiple, I've had surgeries over the years, and I've been prescribed opioids. I could get caught up in that. So people that see multiple doctors, have a lot of doctor visits, may tend to have a lot of opioids and pain relievers prescribed to them. Oftentimes the temptation is to use somebody else's prescription, not for bad reasons, but it's healthcare is expensive. And if you're suffering of pain, or if you think you have an infection, it's not unusual for people to try to use family or friends' prescriptions, whether it's antibiotics or painkillers. So that can also lead to this issue. Folks who use IV drugs are at higher risk, and people who've been former users who then fall back and begin using again. When I think of pain relief and I think of opioids, that's also a risk. And a lot of times in healthcare institutions and long-term care facilities and in private residence, we'll come across people that are prescribed multiple pain relievers, not understanding that both the pain relievers may be opioids, because again, they're getting prescriptions from 2 or 3 different doctors, and the doctors may not know what the other doctors prescribed because the patient's just not aware of all the different medications. Pain patches are often used, and it's not too uncommon to go to a call or have to take care of somebody who has multiple patches on them. When you take their shirt off and you look at their back, you see 4 or 5 patches. Medications, multiple medications, benzodiazepines combined with opioids can lead to more problems. Antidepressants. Throughout COVID, in our first presentation of mental health, we we talked about the addiction to alcohol, and alcohol consumption is just going through the roof. So people that start to use opioids and also have alcohol dependency issues. And what we've been seeing locally in the state has been an increase of children who accidentally take these painkillers or methadone that's prescribed to their parents. We've had kids as young as toddlers under the age of 2 accidentally overdose. And we've had other kids a little older taking the pills. And there's really no outward clue other than the somnolence and the decreased level of consciousness, and in some cases, the pinpoint pupil. So it presents a challenge for EMS because you don't normally think of a child as possibly overdosing on opioids, but we've noticed that that has also been happening. So when you think of prevention, we always think of locking up your prescriptions and keeping them away from children and out of their reach.
So everyone can hear me, correct? All right, perfect. So to continue off of what Paul was just saying, we really had to look at what the problem is, especially coming from a law enforcement perspective, especially with COVID in place. Yes, we saw increases in alcohol consumption. We had an increase in the number of calls for service for intoxicated parties, for overdoses. We started a few years back looking at this problem, like how can we better address the problem? Because, right, this is a community problem. I just put it simple, it's a community problem. How do we fix this? Or how can we at least try to carve a path to really help people out? Because again, it impacts the community. In some cases, there's crime associated with alcohol and narcotic use. It impacts our healthcare system, especially the hospitals. I mean, they're already inundated with COVID, and they have to worry about that. And here we have people going in for alcohol abuse, for narcotic abuse. So how can we lessen these issues? What kind of intervention can we put in place? So again, we took a different approach. I partnered with the Litchfield County Opioid Task Force. Thankfully, I met quite a few people here. Lauren was able to step up and help out, and we developed a new approach, and it became our community outreach program initiative, where now we will respond with a recovery coach who has lived experience to all overdoses. He gets notified now through our dispatching center. He responds to the scene, meets up with either me or some other officers, and we look at the individual and we try to figure out what's the best option here. We establish a rapport. We try to connect them with services, and if again, the initial interaction is just what do we need to do now? Is it hospitalization? Is he going to be okay, or is she going to be okay for right now? Establish that rapport and then follow up, which again, I know several agencies are starting to do that now, but before it was never really part of what we do. I think the collaborative approach to getting people help, and it definitely expanded beyond that. I mean, not only are we doing opiate overdoses, but we follow with people who alcohol consumption. We have now trauma. We have community partners that we work with, where if we have people that need trauma support, we can definitely refer people to, or we can at least connect them with therapists and counseling services. So again, it's all about, not just our position as law enforcement, but what can we do as from a support position? How can we all work together to actually help people, get into recovery and, again, lessen the impact on all the other systems in the area. Really all about communicating, working together, which again is sometimes is difficult. It's always been a difficult issue. So again, we've made a lot of movement in the area, especially in Litchfield County. I just want to throw it out there too. We've been working with Western Connecticut. I know it's not really part of this, but you want to talk about mental health, like Paul mentioned before, mental health is huge. Especially with COVID, depression, anxiety is going up. We have all these other things going on. Now we can call Western Connecticut, which is right in town. They can come out to us. They can follow up with people. So again, you suddenly have this established partnership with community members and community programs, and actually are making a difference. You're getting people help, or at least connected with resources that they may not even know about. So there's been a lot of good stuff. I gotta say, it's been quite a few years in the making, and we've come a long way, especially in this area. So, all right, we'll go to the next slide. The Good Samaritan laws. I actually just wanted to go over this, and I just want to make sure it's clear, especially because sometimes there's still confusion out there. The Good Samaritan law was passed in, I think it was 2011. I just want to make sure it's clear. When you call 911 because there's an overdose occurring, there's no need to fear any type of criminal prosecution for narcotic or drug paraphernalia. People still think, I don't want to call law enforcement. I don't want to call 911 because I know the police are going to show up, and what are they going to do when they come here? Our priority from a law enforcement perspective is to get people help. It's not to say that, I know there's a little caveat on this where it says, if you have a warrant or something like that, yeah, we have to address it. But our goal is still the same with everyone else's. It's to make sure that person's safe, to get them connected to the ER, because I don't want anyone passing away. Doing this job for 12 years, and I'm sure everyone else that has the same experience have seen the worst. We've seen people passed away. And it's traumatic. I've had to hold people, family members, children, friends that have lost loved ones or are going through this and they don't know what to do. I don't want them ever to fear calling us. Our goal is to help people. I want to make sure that's clear. You can call us. We're not here to, take people away. It's to get people help. This is expanded. The Good Samaritan law in Connecticut has expanded with different public acts. 2012, we started incorporating Narcan. So there was protection against civil liability and criminal prosecution if you were to give people Narcan to use it. If you suspect an overdose, there's protection against any civil or criminal prosecution against that. And I think in 2015, it allowed pharmacists to actually dispense Narcan directly to customers, which was a huge step in the right direction. All right.
When we think about risk factors, mixing drugs, Sergeant Kelly just talked about, and Paul was talking about the alcohol, mixing alcohol with opiates. I mean, there's never a good outcome there. Injecting the drugs directly into your system is definitely a risk factor. And when we talk about changing tolerance, sometimes say a person is using 10 bags a day and he has a problem with it and goes into a detox for 5 to 7 days. Excuse me. And now while he or she is in the detox, he's getting a lower dose of methadone and he's being detoxed slowly, so that on the 5th or 6th day when he completes the detox and is discharged, best practices is to try to get him into a 28-day program directly door to door from the detox to the treatment facility. A lot of times that doesn't happen. Bed availability, or for whatever, maybe the client doesn't want to go into a long-term or into a 28-day program, and they have every intention to not use, and they go back home. The next day when they wake up, they're getting ready to go to work or whatever, and they run into that guy that they get their heroin from. They believe that they can go right back to the same amount that they were using prior to detox because that was their habit. The tolerance level has dropped significantly. Even over that short period of 7 or 8 days, the tolerance level has dropped significantly. And the risk is so much higher for overdose once you've stayed away from it for a while. Drug strength and contact, Sarah touched on it very well as far as the fentanyl and the carfentanil. Things are changing. The ingredients in the drugs are changing. The strength of the drugs are changing. Very high risk factors with, some people go out there just to buy heroin, and the dealers are mixing the carfentanil in with it or the fentanyl in with it. That increases the strength of the heroin, unbeknownst to the end user, and overdose is the end result. the strength content is a very high risk. Using alone, we recommend that nobody uses alone. So many things could go wrong, and once they do, there's nobody there to help you. And physical health, as we move along, and in our using behaviors, it deteriorates. It starts to work on our bodies physically, and our health begins to deteriorate. And believe it or not, I'm sure that has something to do with our tolerance levels too. As time goes by, we're not as physically capable to handle the amount of drugs that we used to do. Example, I'm a person in long-term recovery. I haven't used drugs in over 30 years. If I, my tolerance level is pretty low, I'm sure. A lot of risk factors out there, and I think the most important one is just don't use alone. You have no assistance available.
So Ralph, when you were talking about tolerance, I couldn't help but, when I talk about tolerance to a lot of people, if we took the example of taking a pain medication or anti-anxiety or a lot of different medication, the more of that medication we take, the longer we take it, our body builds a tolerance to it. So then we need a higher dose and a higher dose. And what I want to walk away with what you're talking about is tolerance is, as you use heroin or any other drugs, you develop a tolerance. So then you need more and more of that drug to get that feeling of euphoria. But when you're in rehab, even though it's for a week or two, that your tolerance really drops significantly. So to start, if you use again, you really don't want to use where you left off a couple of weeks prior. And you were mentioning in a conversation that sometimes it's only 2 weeks and your tolerance can really drop. Can you expand on that a little, please?
I mean, obviously, the tolerance levels are different for each of us individually. But let's say, as I referenced earlier, if you're using 10 bags a day for two or 3 years, and then you go into a detox, and you're in a detox for 5 days, and maybe you go into a treatment facility for a week or two, and you're away from drugs completely during that time. When you come back out, I'm not going to tell you to use three bags and get back up to 10, but I would start low and move back up to where for the effect, because of the lowering of the tolerance in your body.
Brandon, you mentioned that in 2015, pharmacists they could prescribe naloxone. And one of the challenges we have in a healthcare system that we're all in, we have access to healthcare is a need. We know that. We see a lot of people using the ED. But what about those folks without insurance? How could we get them naloxone? Can the local pharmacies provide them naloxone? How do we cover those expenses? Because at the end of the day, everything has an expense. Is there any avenue for people to get naloxone for free if they went to a local pharmacy? And I know that Petrichone's pharmacy does do the prescriptions and does dispense naloxone. Can anyone jump in from our panel and answer that, please?
Sure, I could take that. So pharmacies, when somebody comes in for a Narcan, they have to run it through the person's insurance. And so that tends to be a barrier to some people either accessing it because they don't want it to go through their insurance, or because they might have a high deductible copay. If somebody has Husky for insurance, then it is no cost. But the pharmacies typically cannot give it at no cost. However, myself, Ralph, Lauren, with our Rovers, there's a lot of ways to get Narcan out there. So we can definitely get that to people. We're happy to deliver it. We can get it to anybody who lives or works in Litchfield County. And we just have a new universal phone number that I believe Lauren will talk about later, that people can call for access to Narcan and other harm reduction supplies.
another chat question, which is actually a good time to jump in, was you talk about harm reduction, and Lauren just answer it. There was a question about, is there a number that we could call a toll-free number if we're going to use, and somebody will stay on the phone, and that number is posted, and it's 1-800-484-3731. And Lauren, since we're on that topic, can you talk a little about that 1-800 number to enable people to use more safely?
Yeah, so I think there's actually several resources out there like this one. I know there's talks as well to have an application where you check in using the application. And if you don't respond in a certain period, it will then prompt a call to emergency services. So basically what it is you call the line when you're going to use a drug. And an operator answers, and if you become unresponsive, they will call emergency services to your location, which they find out that information, I believe, beforehand.
So some of this got covered, not using alone, but it's really important because if people are not using safely, if they're using alone, they're by themselves, then people are more likely to die from an overdose. One of the main things, and a very good friend of mine tells a story about when her daughter was overdosing. There was so much shame in the house. There was people that they didn't want anybody to know that their daughter was struggling with addiction. They had a Narcan kit in their house, but when they needed it, when the daughter was overdosing, they couldn't find it. So we want everybody to have a Narcan kit in their home. We recommend that people put it in a place where people will know where it is. I always recommend people put it in a first aid kit and have it ready. Now, we don't necessarily have to assemble Narcan kits anymore because we have these nasal Narcan sprays, but there are some out there that people do need to screw pieces together. So it's important to have it ready. And if somebody isn't responding, if somebody doesn't come to, then hopefully there's somebody there that can help to resuscitate them. Because if, like I said, if somebody is by themselves, there's not going to be anybody there to help. I have a parent that I work with that will go in and check on her son every once in a while just to make sure that he is breathing, because she knows that he's up there in his room using by himself. There's a lot of shame, a lot of stigma, and that's what's killing people.
Just to add on, Sarah, that case you brought up, I'm very familiar with that case, and they kept it on the refrigerator for a couple of weeks, and the daughter kept complaining, "Why are you leaving it there? Why are you leaving it there? I don't want anybody to know." And in that case, the night that she overdosed, she passed away because it was not readily available. Everyone in the house should know where that is, and it should be kept in the same place at all times.
Absolutely. It's the shame of it that ultimately killed her. So creating an overdose prevention plan, although it might sound kind of cheesy, we create plans for getting out of your house in the event of a fire. We create plans for if there's an emergency situation, where you're going to go, what you're going to do. So having an overdose plan and having people also know that plan that are nearby is important. People are at greater risk for overdose if they've overdosed before. There's a statistic, it's pretty alarming, that says that somebody who's had an overdose, there's, I'm not sure the exact number, but more than a 50% chance that within a year that same person's going to have a fatal overdose. Keep naloxone nearby, like I said, very important to know where it is. Put it in your first aid kit so that you always know where it is. Do not share prescriptions. Don't mix pain medication with alcohol, benzos, sleeping pills, muscle relaxants, or other opioids, especially because a lot of these things now are being laced with fentanyl. So we know that heroin is not heroin anymore. There's a lot of fentanyl or other things in heroin. And then people are also taking maybe a benzodiazepine that's laced with fentanyl. You're getting double dosed. And so that's when a lot of overdoses are happening. Lock up your medications. Like we say, don't share your prescriptions. There's a lot of people that, for no fault of their own, especially older individuals, that people might go into your home and go through your medicine cabinet, or just take it because they need something, and you just don't want to risk that.
Now we think of we've been talking about opioid overdoses. We've been talking about the side effects of a toxic overdose of opioids. But when we think of an opioid overdose, we think of somebody who may be somnolent, not arousable, not awake. They're not responsive to touch or voice, or perhaps they have snoring when they breathe. They snore, or they gasp and their breathing is irregular, or their chest is moving very shallowly. Oftentimes their pupils are really constricted. The fingernails were turned blue, and you'll see blueness and purple lips when you look at that person. When feeling for a pulse, when you think of CPR, their pulses can be very slow, very weak, and in some cases, not even you can't even detect a pulse. They're not palpable because they have such a low blood pressure.
As I've mentioned a couple times, we're seeing a lot of laced substances. Now in Connecticut, there's been a lot of rumor that there's marijuana laced with fentanyl, but as far as I'm aware, the high intensity drug trafficking doesn't have any real info that actually exists. But we want people to be aware that that is very possible. It could happen, especially with the legalization of marijuana. Xanax is being regularly laced with fentanyl now. Street pressed pills, Xanax, tramadol, oxycodone, lots of different pills. And they put these pills in front of very well trained pharmacists that couldn't tell the difference. And so it's very dangerous. People don't know the difference. Kids get their hands on these things because, I'll just take a Xanax. Well, if it's laced with fentanyl, next thing they're overdosing. We do have fentanyl test strips, and we encourage people, especially using pills, any powdered substance, to test their substances before use, so that at least you know that there's fentanyl or not. It doesn't tell you how much fentanyl is in it. It just says yes or no. And the image on the right, the heroin to fentanyl to carfentanil comparison, this is how much it actually takes to cause an overdose. The amount of heroin to the amount of fentanyl, and then carfentanil, it's 100,000 more times potent than morphine. So it takes a very minimal amount to cause an overdose. And so when we're seeing these things that are being laced, it takes nothing at all. And people will say, well, how can a drug dealer do that to somebody? Or I know my drug dealer, they wouldn't do that to me. They don't even know. The things are being laced during the actual cutting process, distribution process, and people have no idea what's in their substance. Oh,
So when
sorry, real quick, somebody just put a question in the chat. Where can fentanyl test strips be obtained? We have them within our rovers, we have different rover locations around Litchfield County, in Torrington, Winsted, Canaan, and Watertown, and we can provide that information for where to get them, or we're happy to deliver them as well.
And we think of where Narcan and how it works, and what Narcan does, it blocks the receptor site. So when you think of our how medications work, they fit within a receptor site, and Narcan blocks that, so it helps with that response. But as we're going to learn when you talk the next slide, or right after this video, is that in some cases with overdoses, the Narcan has a limit. It only has a shorter acting life. What I'm going to now do is just show this video that talks, does a quick review of some of what we spoke about, and it talks about using this nasal spray. Can everyone hear this?
No, the audio is not working.
Way for you to help someone who is experiencing
hear it
an
now?
opioid
Yes.
overdose, even if you don't have specialized medical training. In this video are instructions for use, as well as the uses and safety information you should know for using Narcan. But first, it's important to be able to recognize the signs of an overdose. Signs of an opioid overdose include not waking up or responding to your voice or touch, breathing that is very slow, irregular, or has even stopped. The dark center part of the eyes becomes very small, sometimes called pinpoint pupils. Fingernails and lips turn blue or purple. A slow heartbeat, weak pulse, or low blood pressure. If someone has these signs, here's how you can help. Narcan nasal spray is a medicine that reverses the effects of an opioid overdose. Narcan nasal spray is not a substitute for emergency medical care. Repeated doses may be necessary. As with any drug, you need to be aware of important safety information about its use. Please pay particular attention to the indications and important safety information at the end of this video. Also, please see the accompanying full prescribing information and the use of this product. Narcan nasal spray was designed for use wherever an emergency opioid overdose happens. Because it doesn't require specialized medical training, it can be given to someone by following these instructions. First, lay the person on their back. Then remove the device from the box and peel back the package. Hold the device with your thumb on the bottom of the plunger and 2 fingers on either side of the nozzle. Tilt the person's head back and provide support under their neck with your hand. Place and hold the tip of the nozzle in one nostril until your fingers touch the bottom of their nose. Press the plunger firmly to give the dose into the person's nose. After giving the dose, remove the device from the person's nostril and move them on their side, positioning their hands under their head. Call 911 and get emergency medical help right away after giving the first dose of Narcan nasal spray, even if the person wakes up. Narcan is not a substitute for emergency medical care. Keep the person under observation. If the person doesn't respond by waking up to voice or touch or breathing normally after 2 to 3 minutes, administer the second dose provided in the box in the alternate nostril. If they respond and the signs of an opioid emergency have returned after Narcan nasal spray is given, then give another dose in the alternate nostril using a new device and watch them closely until emergency help is received. Additional doses may be given every 2 to 3 minutes until they respond or emergency medical help is received. After using Narcan nasal spray, put the device in its box and then dispose in a place safe from children. Narcan nasal spray delivers a consistent, concentrated 4 milligram dose of naloxone that can reverse the effects of a life-threatening opioid overdose in minutes. Visit Narcan.com to learn more. There's a way for you to help someone who is experiencing an opioid overdose, even if you don't have specialized medical training. Indications and important safety information. What is Narcan nasal spray? Narcan nasal spray is a prescription medicine used for the treatment of an opioid emergency, such as an overdose or a possible opioid overdose with signs of breathing problems and severe sleepiness or not being able to respond. Narcan nasal spray is to be given right away and does not take the place of emergency medical care. Get emergency medical help right away after giving the first dose of Narcan nasal spray, even if the person wakes up. Narcan nasal spray is safe and effective in children for known or suspected opioid overdose. What is the most important information I should know about Narcan nasal spray? Narcan nasal spray is used to temporarily reverse the effects of opioid medicines. The medicine in Narcan nasal spray has no effect in people who are not taking opioid medicines. Always carry Narcan nasal spray with you in case of an opioid emergency. Use Narcan nasal spray right away if you or your caregiver think signs or symptoms of an opioid emergency are present, even if you are not sure, because an opioid emergency can cause severe injury or death. Signs and symptoms of an opioid emergency may include unusual sleepiness and you are not able to awaken the person with a loud voice or by rubbing firmly on the middle of their chest, breathing problems including slow or shallow breathing and someone difficult to awaken or who looks like they are not breathing. The black circle in the center of the colored part of the eye is very small, sometimes called pinpoint pupils, and someone difficult to awaken. Family members, caregivers, or other people who may have to use Narcan nasal spray in an opioid emergency should know where Narcan nasal spray is stored and how to give Narcan nasal spray before an opioid emergency happens. Get emergency medical help right away after giving the first dose of Narcan nasal spray. Rescue breathing, or CPR, may be given while waiting for emergency medical help. The signs and symptoms of an opioid emergency can return after Narcan nasal spray is given. If this happens, give another dose after 2 to 3 minutes using a new Narcan nasal spray and watch the person until emergency help is received. Who should not use Narcan nasal spray? Do not use Narcan nasal spray if you are allergic to naloxone hydrochloride or any of the ingredients in Narcan nasal spray. What should I tell my healthcare provider before using Narcan nasal spray? Before using Narcan nasal spray, tell your healthcare provider about all of your medical conditions, including if you have heart problems, are pregnant or plan to become pregnant. Use of Narcan nasal spray may cause withdrawal symptoms in your unborn baby. Your unborn baby should be examined by a healthcare provider right away after you use Narcan nasal spray. Are breastfeeding or plan to breastfeed? It is not known if Narcan nasal spray passes into your breast milk. Tell your healthcare provider about the medicines you take, including prescription and over-the-counter medicines, vitamins, and herbal supplements. What are the possible side effects of Narcan nasal spray? Narcan nasal spray may cause serious side effects, including sudden opioid withdrawal symptoms. In someone who has been using opioids regularly, opioid withdrawal symptoms can happen suddenly after receiving Narcan nasal spray and may include body aches, diarrhea, increased heart rate, fever, runny nose, sneezing, goosebumps, sweating, nausea or vomiting, nervousness, restlessness or irritability, shivering or trembling, stomach cramping, weakness, increased blood pressure. In infants under 4 weeks old who have been receiving opioids regularly, sudden opioid withdrawal may be life-threatening if not treated the right way. Signs and symptoms include seizures, crying more than usual, and increased reflexes. These are not all of the possible side effects of Narcan nasal spray. Call your doctor for medical advice about side effects. The risk information provided here is not comprehensive. To learn more, talk about Narcan nasal spray with your healthcare provider or pharmacist. The FDA-approved product labeling can be found at www.narcan.com/pdf/narcan-prescribing-information.pdf or 1-844-4NARCAN. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see full prescribing information, including the patient information for Narcan nasal spray.
So, when we talk about Narcan, Narcan, lasts for about 30 to 90 minutes. So that's why it's extremely important that, these patients do get transported to the hospital because they really need more treatment possibly later on. Depending on how much opiate they have taken, sometimes after a while, this Narcan will wear off and they're going to need some more. Again, like that was spoken about in past, Narcan will not reverse other types of overdoses, such as cocaine, alcohol, benzodiazepines, or methamphetamines. However, a lot of times, some of these patients have taken numerous medications. So, they may have cocaine on board as well as an opiate. So if you're really unsure and they are unresponsive, really the best thing to do is to give Narcan, and you're certainly not going to hurt them.
Thanks. Sarah made mention of that Narcan comes in different forms, and the second image below is the kit that has to be assembled with an atomizer, and the dosages and the concentrations are different. I do want to just kind of go back to the Narcan that was demonstrated in that video. That has the best concentration, and that's going to work better than the other forms of naloxone. The one at the bottom is just a needle. So naloxone can be delivered intranasally through an aerosol mask, similar to how albuterol is delivered, intravenously, intramuscular. But the nasal route that we just started to use in the last decade or two has really been great because it allows anyone to administer it very easily. we think of that initial response. So we do our typical CPR assessment, shake and shout, and assess the person. Oftentimes, if you suspected a Narcan overdose, or excuse me, an opioid overdose, administer the Narcan sooner. Calling 911 does take a little time, so there'll be a lot of questions. So it doesn't take but less than 60 seconds to administer the Narcan. So administer the Narcan, provide that initial life-saving measures to the victim. 911 is great. So as they ask you a lot of questions, they'll also walk you through instructions, and they can walk you through rescue breathing and CPR. And really the key here is also to just stay with the person, monitor and support them as you're able to.
Yeah, like Paul said, when you call 911, the dispatchers will ask you a lot of questions, and it's routine for a majority of the calls we go on. And going back to the other sides as well, you know, administer a Narcan. If you believe it's an overdose, like you're seeing the signs, symptoms that the video covered and everything that we covered in this PowerPoint, give the Narcan first, call 911, and just stay with that person. And they're going to ask you a series of questions. You know, what is the person going through? What do you see? They're going to ask for specific details, because these are pertinent details that are going to be relayed to EMS and law enforcement and fire as we all are responding to the scene. We want to know, you know, are they breathing? Are they not? Is it agonal breathing? Are they gasping for air? These are all things that we have to monitor, especially getting there. If you do have to leave the person alone, obviously place them in the recovery position. If you use Narcan, make sure you hold on to it. Let us know, because we do want to know this. Fire, EMS, and law enforcement all carry Narcan on us. So if you don't have access, you know, we will have some to use, and we will use and monitor, and we'll be looking for that type of reaction. If we use it and have that reaction, the reversal effects, and, you know, usually they come too, but it could take time. Depends on the dose, depends on what's getting mixed in and what else is on board. And like Jeff said, there could be multiple narcotics. There could be narcotic and alcohol consumption. We've seen it multiple times where sometimes we see change in, you know, their medical condition, but, you know, the best course of option is obviously to go to the hospital. We want people to get to the hospital for that appropriate level of care. I've seen this stuff, you know, people come to, they have Narcan on board where, hey, you know, they feel a lot better, and they think, hey, you know what, I don't need anything else. Thank you for coming. But I've also seen that reverse. You know, once it starts wearing off after the certain period of time, and, you know, our biggest concern is obviously just making sure that person's going to be safe and will get the appropriate level of care they need, not just an Narcan and move on. And just, again, to follow up is, you know, once we have that connection, I have Ralph Baker, who's on the line here, who will be there. You know, he gets the notification as well through our dispatching center. As soon as there's a report of an overdose, he'll get the notification to respond out to the scene. He'll meet with officers, and he'll meet with the person that overdosed, and again, make that connection and see, you know, what kind of plan we can have in place. What's the appropriate course that we need to go, whether it's to go to the hospital, or if we're not yet there, or if it's not where it should be, we can at least make sure we can have some type of safety plan in place, that we have that safety net where we can actually help someone out. We'll be following up with that person consistently within a 24-hour window, and then later on that week. So again, it's, you know, administer Narcan as soon as possible. If you believe it's an overdose, call 911, and just, they're gonna ask you a series of questions. Be patient, make sure that you get all the information out there, and we'll make sure that, you know, Ralph will be connected with anyone. And again, family, friends, it doesn't matter. We have support services that we can connect people to. So again, we want to make sure everyone as a whole is taken care of, and at least has the support necessary to get through this.
Thanks. If you look at the chat box, Lauren just shared a website that provides some information to getting Narcan fentanyl testing strips, and the website is right in the chat box. And when we close this presentation, my follow-up tomorrow will be some of these resources that are available. So as I ask all the speakers that are sharing this great information, please follow with an email tonight. I'll compile everything in one email and I'll send it out to everyone that registered, including a couple of helpful training videos to support this.
So, what not to do. The most, I think, important thing to do is not to leave the person alone. Like Sergeant Kelly said before too, nobody is going to be in trouble or be arrested. It's important to remain on the scene, to assist that patient, to give us information when we arrive in the scene. As much as you can. It's important for us to know possibly how many bags, the patient has consumed, how they consumed it. If you're familiar with that patient, any medical history that they have, a lot of these things are very important to us. And again, I can't emphasize enough not to leave that patient alone. Never put the patient in a bathtub. I know Paul and I have seen this was something that was really more done in larger cities. When we worked in Waterbury, we used to find patients laying there with like a bag of ice down their shorts. And really the only thing that does is just give you a cold crotch. It really does absolutely nothing. So the most important thing that you can do is stay with them. Never give them something to drink, and obviously never inject anything into them, salt water, cocaine, anything else. If you have the Narcan, use it and assist that patient until EMS or fire and police arrive.
Jeff, in order just to add on to that too, when the person that overdoses comes to, and there's 3 EMS, 2 firefighters, and 4 cops in the room, and the person that he was getting high with is there with him, he'll feel a little more comfortable and be more addressable. You know what I mean? If he wakes up alone in that room with all those strangers, he's going to be a little harder to deal with too.
No, you're absolutely right. It's kind of a buffer between us and the patient.
Yeah, we talked about using Narcan and how it really makes a big difference. When they first talked about using Narcan prior to making it so readily available, we were talking about expanding the EMS role and who could administer Narcan, because 15 years ago, it was only a paramedic that could administer it. And when there was talk about them allowing EMTs, EMRs to administer Narcan, there was actually some resistance because people felt it would be unsafe. But when you look at the science and look at the facts, the fact is that it's safe. But there's some side effects that may result, and those may be seizures. So you may administer Narcan, you reverse the opioid overdose, but the person has a seizure. Or somebody could have a seizure because of an overdose because of the lack of oxygen and how it impacts their brain. In some cases, people may have seizures because of a heart irregularity. But when you see somebody seizing, and it might have been after giving the Narcan, stay with them. Keep them safe, meaning don't make sure that they don't bump in anything or anything falls on them. Try to roll them on their sides. So if they do vomit, you're keeping their airway open. And what you try to do is not to physically restrain them because you can hurt them, and stay away from putting things in their mouth. People used to try to put airways in, and they would have to wrestle and muscle and open somebody's mouth up, and it caused more damage than it didn't provide any good. It just did more harm than it was supposed to. I'm going to let have Lauren jump here, kind of talk about all the different resources we have available, talk about the Litchfield County Task Force. So thanks, Lauren.
Thanks, Paul. So you've heard about quite a few of our resources already. We have, through the task force, multiple programs across different communities where we're working with law enforcement and partnering them with recovery coaches. And then we also have our addiction resource line that Sarah mentioned. So this is a brand new program that we've just launched through the collaborative effort of all of our county's outreach staff. And through that number, folks can call, get information on where to get Narcan, where to get resources, how to access treatment if they need help navigating recovery, if it's a family that needs help navigating their loved one's recovery or use. This is the perfect line for that. It's not a crisis line. We still ask that people call the crisis line like 211 or 911 if they're having a crisis, but for general information, resources, and assistance, you can certainly call our resource line, and I'll put that number in the chat as well. And then we have our harm reduction services, which is where we offer Narcan. We call them the rovers. They're mobile toolboxes that carry Narcan, safe injection supplies, things like fentanyl testing strips, which we discussed before, things to keep people safe and alive until they're ready for treatment. So these are all different programs that we put on through the collaborative effort of the Litchfield County Opiate Task Force. Lots of great resources. You can find out more on our website. It's lcotf.org. Oh, Paul, you're muted.
Lauren's going to share all those resources with me in an email, and tomorrow morning I'll follow up and send all this to everyone that's on this call and those who signed up and couldn't make the presentation. So Lauren, do you want to add anything else to the opioid task force? You covered it pretty well.
I guess I will say that this is a community, truly a community collaborative. It has multi-sector representation, and it is open to it's an open meeting. So if folks want to participate in this work, they're more than welcome. They can just reach out to me to become involved.
Right. So this is an opportunity now as we move forward to the closing, is to, if anyone has any questions or they want to ask a question, just shout out in the chat box. I'm going to ask one question, then I'm going to stop the recording so people can have a candid conversation. And working in healthcare for a long time, working with police, EMS, and healthcare providers in the hospital, in the pre-hospital setting, initially when, this is going back a few years, when you heard about this harm reduction strategy and you heard about Narcan, one of the first things I would hear people say is, you know, if we teach them how to use, if we provide them with clean needles and so forth, are we enabling them and actually exacerbating, making the problem worse? I know that's not true. Is anyone on our panel that might want to explain why doing these preventative measures that we do in public health don't enable and don't exacerbate the problem, but they actually help the community?
I'd be happy to talk a little bit about that. So a lot of that misunderstanding in harm reduction causing enabling is really based in kind of that chemical hook model, where if somebody uses a drug, you know, that's their own moral failing, and now they're stuck in that pattern of drug use, and that's their own fault, and we should not help them. So what we really do is we look at addiction at the root causes. So the things like trauma, or, you know, that could be anything from child abuse to losing a parent, all sorts of things can traumatize somebody. And a lot of folks who have addiction have a trauma history. So we recognize that addiction is more than just a chemical hook. There's a lot of things that drive it at the roots. And by looking at it through that lens, we're able to implement these public health strategies that just make sense. And the data does show that harm reduction works. It keeps people alive, and it empowers people who use drugs to make safer decisions and to have, you know, a better knowledge of when they're ready, where to get resources, and so forth.
Now, my
Lauren, that's exactly, I mean, you did a great job of explaining that. And as a person in long-term recovery, the first time something goes wrong, I'd like to stop using drugs. A lot of people would have liked to stop using drugs or stop the drinking and stop that stuff. Addiction and the stuff that goes on in the brain doesn't allow that to happen right away. However, the next time, I mean, I know I've worked with guys that have been in 18 to 20 rehabs, and when they got out that 21st time, they got clean, and 4 years later, they're back to work full time and they're contributing members of society. I know a lot of successes that have come from people that have been helped to get through that time that they were struggling, and you know, harm reduction is definitely an avenue to make that happen. I've seen plenty of successes with that.
Thanks, Ralph. So Brandon, my next question is really directed at you. So, 15 years ago, if you thought of a police department, you thought of regulatory, punitive, and we're going to arrest you. And what now you've described is really this different approach. And you emphasize the community response, the community approach from the police department. And the police department has actually really expanded their outreach into the community. You mentioned something about if you were to go on a call and there was an overdose that was reversed, that you do some follow-up. Can you elaborate on the follow-up that you do as a police officer in your role?
Sure. So whenever there's an overdose, back in the day, 10 years ago, 15 years ago, like Paul said, this wasn't really a thing. We never followed up with anyone. It was, the overdose, all right, let's send them right to the hospital. And that was the really only option. There wasn't much out there. What do we do? And then, the whole community partnership, we operate in our own, they always use the term silos. Like we operate in our own little, area, and then we don't communicate. We don't know what's going on, and we move on, or we think we do. And then, occasionally we'll find that a person overdoses again, and again, we don't fix the issue. So now we took a different approach. So when a overdose occurs, like I said before, Ralph Baker gets a notification, which is our recovery coach that will come out to the scene with us, and he will make that initial connection with the individual. Once that rapport is built, and I've seen it multiple times already where, they may feel a little uncomfortable speaking to an officer. I get it. Sometimes it's an uncomfortable situation, especially with previous stigmas of, hey, I'm going to get arrested, which is not the case anymore. It's, how can we establish a better rapport? And now I have someone that, not only has gone through it before, but is here to help. So Ralph will follow up, or we will actually follow up within a 24-hour window. So the next day, we try to aim for the next day, depending on the staff and everything else, it might be 2 days, but we check in and that's something that was never really established before. Why would an officer check in? And, I like to remind people, and I grew up in Torrington, so, I take it to heart, is I actually care about the people. Like I care about, it's the reason why I became a police officer. And sometimes we forget, doing this job is, we're here to save lives and find a way to help people. So we now go to the house where it happened or wherever a person feels comfortable the most. We'll check in with the person who overdosed. We'll check in with friends and family, see how they're doing, see if there's any services that either Ralph can help them with, or if any of our partners of the Litchfield County Opioid Task Force has, or anyone that we know of, we'll try to reach out to them, try to connect them if they want it. You'll make the phone calls right from scene. Like again, our goal is to make sure they have that support network. And then within every week, we've been trying to aim for just to get out there. So we'll follow up with people, whether it's by phone call or showing up to their residence or wherever. And we try to follow up with people, see how they're doing. We'll do walkabouts in the community. We'll go down to parks. We'll go down to the shelters and really try to reach out and make sure everyone knows that we exist, that, there are services available. There are ways to get Narcan. There's ways to get enrolled into services. And again, that's huge because as a police officer, as people know, and we're 24/7. We operate on a 24/7 basis. So if there's a call, whether it's in the middle of the night or in the middle of the day, we're going. So now we have, that anchor point of, okay, well, if police are always going to get called, why not do a collaborative approach? It was good. I think it's a new type of policing. It took a lot of, buy-in. I have a lot of support from the department, which is nice. I have officers, again, like you mentioned before, the concept of getting people help, and finding a way, this is brand new stuff that we've really been getting involved with. I'm starting to see it pop up everywhere. There's different types of programs. I learned a lot from all over the state. I visit a lot of departments, Naugatuck, Waterbury, Meriden. I mean, there's different versions of people doing the same type of work. We're here to help. And I think we've been going in the right direction. It's been good. It's been nice to actually be part of the community and be out there and have people not be afraid anymore, to understand that You know, we're not the bad guys, and we're not there to put you in jail or issue a fine. It's no, we actually care, and we want to make sure that you're doing okay. And the response I've gotten from the community alone, just showing up, hey, why are you here? I'm here to make sure you're doing okay, usually blows them away. They're not used to it. They're not used to that whole, you know, supportive part of policing. And I think we just need to remember that this is a community as a whole. It doesn't matter who you are. It doesn't matter where you come from. It's, you know, we're here to help you. So.
Thank you.
Yeah.
So I've got 3 questions for the panel. So Ralph talked about detox, and then he went from detox to talk about rehabilitation. What's the difference between detox and rehabilitation? Ralph, would you just want to spend like 60 seconds and just kind of go into the differences?
Sure. Well, the detox is a medical monitoring of the safe detoxification, getting that stuff out of your body. There's not a big chance of death with opioid detox, but with alcohol detox, the chance of seizure is prevalent, and can end in death if it's not medically monitored. It's usually a 5 to 6 day period, and there's a medical process they use to detox you from opiates. At the end of that 6 day period, a lot of times there's a 28-day program that provides inpatient at an inpatient facility that provides education, group counseling, individual counseling, and psychoeducation on developing living skills and stuff like that in the 28-day program. The best treatment outcomes happen when they're transported right from detox door to door to an inpatient treatment facility. And those usually last about 28 days.
Thanks. So my next question is really directed to the folks that do that counseling. So it'd be McCall and Greenwood, so both Lauren and Sarah. So Ralph talked about 28-day rehab, and the first thing I go to is my insurance. Will they pay for it? It's expensive. Are there any programs out there to help facilitate getting people in a rehab setting to make it work? And if they needed the rehab and they needed access to that healthcare system, who can they call? Who can they reach out to?
So people like myself, I'm a recovery navigator, and I help people to get into treatment. Same thing with Ralph. We have a lengthy list of people in Litchfield County that do this type of work. So any one of us are very happy to assist people to try to get them into rehab. Insurance covers these programs, rehab. There is a list of different rehab facilities that accept things like Husky Insurance. It's ctaddictionservices.com. And if somebody didn't have insurance, there is limited number of programs that might be available through scholarships or other different kinds of programs. But we can also assist people with getting signed up for insurance if needed. We don't want there to ever be any barriers to people accessing treatment. And then it's also important for people to think of a long-term plan. So when I'm working with somebody through recovery navigation, I will sit down and I'll say, how do you want this to look? Addiction is not cookie cutter. So we don't ever say, oh, you have to go to detox, you have to go to this, you have to do that. We figure it out together. So if there's a certain thing, if somebody's working, there's ways to get people treatment. And then long-term treatment, getting people into counseling, that's certainly something that there's a lot of different programs that could help. We offer financial assistance at Greenwoods. Again, we don't want there to be a barrier to anybody accessing treatment. And so if you're not working on that trauma that was mentioned earlier, the root cause of addiction, you're less likely to be successful in your recovery. And so we find people to be very successful when they're addressing those root causes of addiction.
Thank you. My next question, Brandon touched a little on it when he talked about his community approach and how we're trying to help the community. Working in healthcare for such a long time, we see what happens, the person that overdosed and maybe they pass on, or maybe they get into rehab, maybe there's anything, or they become a frequent patient of ours that we're picking them up numerous times, or they're accessing healthcare. A lot of times this impacts the family unit significantly. So we just don't have the patient that's overdosed, but we have their family. In some cases, when there's a fatality, I'm kind of like overwhelmed because you have this grieving family at their loss. So we're trying to manage the scene and work with the police. But how do we get the family help? Is there any, where can they get help for their, whether it's grieving or the suffering that they do, and get some support? Does anyone want to jump in or have?
Oh, I'll just touch upon it real quick. That was something that I mentioned briefly, and it wasn't until recently I really started focusing on that, mainly because one of the more recent cases where I had family and children and everything else, and they were devastated because they had no clue. And it was just showing up. I'm watching everyone leave, and everything's all done, and yet here we are. We have this huge void left. And again, maybe it's not our position, but I thought it was necessary to realize that these people truly need help. And we forget about that sometimes, because again, we get so focused on the patient, or what's going on, or what do we need to do, protocol. But I think it takes a lot to just take a step back and be like, all right, well, what can I do? And I know Sarah has been great, and Greenwood's counseling has been awesome. If I ever need anything, I know I have a few contacts. I know Western Connecticut is fantastic. I know, we have this huge belief that it was just for crisis intervention, but in recent conversations, we've established this good rapport where they'll come out. They know me well enough, especially if I need to have them come out, just to talk to someone. Hey, is there any support services in the area? Is there anyone that we can reach out to? So we have those connections in place where we don't have to leave people anymore left with nothing. It's, hey, I can make that phone call. I can get people here now, or to make that phone call to you. What do you want? So they're in place. I mean, the services and systems in place. You just have to make a phone call. And we have people that are willing to step up and really go there and go to the scene. No longer do you have to go to a facility anymore to get that help. It's, we'll meet you. We'll come to you and make sure that you're okay. And then we'll go from there, and you set up a plan from there.
We just had that happen. Myself and Western Connecticut Mental Health showed up at an overdose death to the family that morning. And they were distraught, and they were actually in shock. But the fact that Western Connecticut was there and myself was there, that we were able to offer services immediately, and just leave some pamphlets there, and just leave some information there for them. And I lined Sarah up right from the house. I called Sarah and said, listen, this is who these people are, and this is what they may need. It works. And the family was very grateful.
So I want to thank everyone who joined this call. I want to thank all the presenters and panels. Does anyone have anything else they would like to share before we close this presentation? If you do, you can just kind of give me a thumbs up or a wave. So I'm going to go to Sarah.
So I do Narcan trainings, and I can do them in person or for groups, organizations. I do them virtually or in person. I'm happy to get Narcan to people, no cost. I can deliver, I can mail it if needed. We, like I said, want everybody to have it and to be trained. So I'm happy to do that for anybody who lives or works in Litchfield County.
Awesome. And I asked all the folks on the panel to make sure you send me your email, contact information, any great resources you talked about, you shared with the group in the chat box, please email it to me. I'll compile an email tomorrow and I'll send it to everyone that attended this. Anyone else like to share in closing comments? So in closing, I just want to thank everyone. Thank for participating with the talk, all the folks doing the presentation. We're really taking a whole community perspective, and we want to help the people in our community. So You have a lot of help, a lot of support, and we will be making sure that we're available and try to fight this opioid battle. So thank you, everyone, and have a good night.
Thank you.